Welcome. In today's Inside the OR episode, we break down the microsurgical strategy and core technical tenets behind tackling one of the most complex skull-based challenge, a bilateral falcotentorial meningioma, where anatomical precision, venous preservation, and perfectly planned interparietal trajectory make all the difference. This is a mildly symptomatic young patient who presented with this bilateral falcotentorial meningioma. We choose a superior interparietal contralateral trajectory to obtain clean access to the tumor vascular supplies and to use this natural vein-free corridor between the parietal and occipital lobes, allowing this maneuver to easily visualize the veins that are displaced by the tumor. This 2 dissection done by our fellows shows the relative anatomy between the interhemispheric window and parietal veins that runs anteriorly and medially. Then, patient is positioned in park bench. The head is 45 degrees tilted with the floor to maximize working corridor while sitting and gravity aiding a clean surgical field. We started the case by exposing the sinus, and a linear incision close to the sinus allows to access while protecting the brain at the same time. Coagulation on cut of this small bridging veins and sharp dissection on the arachnoid is key to access the interparietal corridor. Here we are mapping the sinus rectus. In this case, retractor is placed over the falx to allow visualization at the depth, and the brain is covered with a tuft. Here in this picture, we can find the corpus callosum, the vein of Gallen, ipsilateral, internal cerebral vein, and the occipital vein that are pushed forward by the tumor. Now the quadrigeminal cister needs to be opened to identify and protect these structures. Here we are seeing the internal cerebral vein and occipital vein from the other side. Goal is here to free the arachnoid adherence between the tumor capsule and the deep venous system. Once these structures are protected, the microscope is tilted backward towards the tentorium. The sinus rectus is visualized and mapped based on our prior coordinates. And once at this point, we proceed with the standard 4D of the meningiomas. First is the vascularization. Even after aggressive devascularization, there is always some venous bleeding from the cavity between both dural leaflets of the tentorium at the level of the edge. Once the tentorium is divided, we use sharp dissection to find the posterior aspect of the tumor behind the quadrigeminal cister. See how I'm pushing the cerebellum down with my suction as I identify both superior cerebellar arteries. Now we have freed the tumor from the arachnoid attachment inferiorly, and I'm protected here with a patty. Now we're going to proceed with some debulking of the tumor to facilitate its rotation from the contralateral side. Here you can use either the sonopet or the side cutter suction device. Tumor is very vascularized, so we need to combine devascularization with bipolar and tumor debulking. We finally extend the cut over the tentorium to completely free the tumor margin of the tumor. And now using Joseph number 4, I continue the blunt dissection and I completely free the tumor margin of the tumor superiorly. At the same time, the falx is acting as contratraction, so I'm able to bring the tumor capsule into the cavity I create. Here you see how I proceed with further debulking to allow further tumor rolling. And now with a sharp dissection, I just cut the superior attachment of the tumor from the falx and tentorium, and I proceed towards the anterior margin at the free edge of the tentorium. Now the tumor is completely free from dural attachment, and now, because we already proceed with a sharp dissection of the arachnoid of the veins, this is just a maneuver in which rolling the tumor while preserving the arachnoid clearly is appreciated by this clean field. I personally like to use this bayonet scissors curved up when I'm dealing with deep venous extractors, as I can use them as a retractor with the belly tummy of the scissors. I also can use the tip of the scissor as a dissection or as a hook, and I also can use it sharp dissection. You see how this clean dissection allows to even see the pre-vermian vein that has been preserved and the superior cerebellar artery that now comes into view from the contralateral side. Preserving the arachnoid is key to maintain all the vasculature from the tectum and the contralateral occipital lobe. I use my suction as a contratraction, and here I'm seeing the contralateral occipital vein. Finally, we just free the last attachment to the tumor from the tentorium in order to see this last portion of the tumor. Tumor capsule is removed in one piece. And we are still dealing with this last portion of the tumor that was attached, the posterior margin of it, to the cerebellum, and we just need to rotate. And as you can see, the falx and the tentorium acts as contratraction. Finally, we were able to achieve grosstotal resection. It's just some warm irrigation needed to achieve hemostasis. We resected the implantation base of the tumor, therefore a Simpson grade 1 was achieved. Pre-op symptoms improved, and the patient was discharged without further deficits. Thanks for watching. Please give a thumbs up if you like it, and follow for more. Thank you.